I performed my last open-heart surgery at age 68. I was skilled. My hands were steady. My judgment was sound. I could have continued for several more years, but I made a choice to stop. That choice was not based on age alone. It was based on something I had learned from decades of operating, something I had learned from the Talmud, and something that modern cardiac surgery is only now beginning to acknowledge. There are certain surgeries that harm more than they help, particularly in older patients. And the tragedy is that these surgeries are still being performed routinely on people over 70, despite evidence that their outcomes are often worse than doing nothing at all. This is not a comfortable topic for the medical profession. I'm about to criticize procedures that generate hundreds of millions of dollars in revenue every year. I am about to suggest that some of my colleagues, many of whom are well-intentioned, have been recommending surgeries that do more damage than good to aging patients. But after 40 years in cardiac surgery, after operating on over 3,000 hearts, after watching people die on the operating table or in the weeks following surgery when they seemed perfectly fine beforehand, I have developed a moral obligation to speak this truth clearly. The Talmud, in Tractate Gittin, discusses the concept of pikuach nefesh, saving a life. It teaches that almost any commandment can be suspended if it will save a human life. But it also teaches, implicitly and explicitly, that there is a difference between extending life and extending suffering. There is a teaching that one should not prolong the dying process artificially. And there is a principle that the elderly have earned the right to dignity, which includes the right to refuse interventions that will diminish their remaining years. These teachings emerged from centuries of observation about what happens when you intervene aggressively in the bodies of very old people. The sages understood, without modern medicine's language, that the body's capacity to recover from trauma diminishes with age. They understood that a surgery that might save a 60-year-old can destroy a 75-year-old. They understood that adding years to life is not the same as adding life to years. Let me tell you about the first surgery that the Talmud essentially forbids, and that modern evidence increasingly suggests should not be performed on people over 70, coronary artery bypass grafting, or CABG, pronounced cabbage in the cardiac world. Coronary artery bypass is the surgery I spent the first half of my career performing. It is elegant surgery. You take a healthy vein from the leg or an artery from the chest wall, and you sew it into the coronary system, creating a new route for blood to flow around the blockage. When I performed this surgery on people in their 50s and 60s with acute heart attacks or severe angina, the results were often life-saving. People walked out of the hospital able to exercise, able to travel, able to live fully. The surgery was justified. The benefit exceeded the risk. But something changed as I moved into my 5th and 6th decades of operating. I began noticing a pattern. I would perform CABG on an 82-year-old man with chest pain and a blockage in one artery. The surgery would go smoothly. But 6 weeks later, the man would not be back to normal. He would be confused. He would be weak. He would be unable to walk the distances he could walk before. His wife would tell me, "Doctor, he was better before the surgery. He was tired, but he was himself. Now, he is not himself." By the time he was 6 months out from surgery, he might regain some function, but he would never return to his baseline. And I would realize, retrospectively, that I had done more harm than good. This pattern is now well documented in the cardiac literature. A landmark study published in the New England Journal of Medicine compared people over 70 with significant coronary artery disease who underwent CABG to people with similar disease who received optimal medical management, meaning excellent medication, careful monitoring, and lifestyle modification, without surgery. The results were striking. There was no difference in survival between the two groups. None. But the surgical group had significantly higher rates of cognitive decline, higher rates of stroke, higher rates of readmission to the hospital, and lower quality of life in the years following surgery. In other words, The surgery did not help. It harmed. The reason is straightforward, once you understand the physiology of aging. When you put an older person on a heart-lung machine, which is what happens during open-heart surgery, you create a state of profound physiological stress. The machine takes over the function of your heart and lungs. It circulates your blood artificially. It oxygenates your blood. But it does this in a way that your aging endothelium, the lining of your blood vessels, finds traumatic. Inflammatory markers spike, microclots form, debris circulates through the bloodstream. Some of this debris lodges in the brain, some lodges in other organs. The surgery itself, even if technically perfect, creates a cascade of inflammation that takes months to resolve, and in many older people, never fully resolves. Additionally, the cognitive decline that follows CABG in older patients is real and measurable. Some patients lose 5 to 10 points on the mini-cog, a standard test of cognitive function, after CABG. This is not trivial. Losing 5 points on the mini-cog can mean the difference between independent living and needing assistance. It can mean the difference between being able to manage your own medications and requiring a caregiver. And this decline can be permanent. I had a patient named Walter, 84 years old, from Philadelphia. Walter came to me with chest pain and significant disease in 2 coronary arteries. The interventional cardiologist wanted to do a CABG. Walter was hesitant. He asked me directly, "Dr. Cohen, should I have this surgery?" I reviewed his case carefully. He was medically optimized. He was on excellent medications. His ejection fraction, his heart's pumping function, was preserved. His chest pain was managed with medication. I told him the truth. I said, "Walter, the surgery will not extend your life. The data suggests it might actually shorten your life when you account for the complications. What it might do is give you a few more years of chest pain-free living, but at the cost of possible cognitive decline, possible stroke, possible weakness, and possible loss of independence. That is a trade you have to make for yourself, but you should make it knowing the full picture." Walter chose not to have the surgery. 5 years later, he is 89 years old. He still has chest pain occasionally, which is controlled with medication, but he is independent. His mind is clear. He travels. He remains engaged with his family and his business. He recently told me, "Doctor, I am grateful I made that choice. I would rather have limitations in activity than lose my mind or my independence." Now, am I saying that no one over 70 should have CABG? No, there are exceptions. If you are 80 years old, but you are extremely vigorous, you have the physiology of a 60-year-old, and you have severe disabling angina that does not respond to medication, and your overall health is excellent, then CABG might still be justified. But these exceptions are rare. Most people over 70 with coronary disease are better served by excellent medical management than by surgery. The second surgery that the Talmud essentially forbids for the elderly, and that modern evidence now questions, is the prophylactic placement of an implantable cardioverter defibrillator, or ICD. This is a device that is placed under the skin near the collarbone. It monitors your heart rhythm continuously. If it detects a dangerously fast rhythm, it delivers an electrical shock to restore normal rhythm. This device is life-saving in certain situations. If you are 45 years old and you have survived a cardiac arrest due to ventricular fibrillation, an ICD is absolutely indicated. It will save your life. But the use of ICDs has expanded dramatically over the past 20 years. Now, doctors place ICDs prophylactically, meaning before any dangerous rhythm has occurred, in people over 70 who have certain risk factors. The reasoning is that these people might develop a dangerous rhythm in the future, and the ICD will be there to rescue them. But this reasoning ignores something crucial. In very old people, a dangerous rhythm that the ICD detects and shocks is often the body's way of saying it is time. It is often the final event in a cascade of declining health. And preventing that event does not restore health. It extends the process of dying. I remember a patient named Eleanor, 81 years old, from Boston. She had reduced ejection fraction from a prior heart attack. An electrophysiologist recommended an ICD placement as a prophylactic measure. Eleanor agreed to the procedure. The ICD was placed. 5 years later, Eleanor developed metastatic cancer. She was dying. She was in hospice care. Her oncologist and her family all agreed that comfort care was appropriate. No aggressive interventions, just management of pain and symptoms. But then Eleanor's ICD detected an arrhythmia and delivered a shock. The shock did not treat the cancer. It did not improve her condition. It simply prolonged her dying process in a way that was uncomfortable and undignified. Her daughter asked me afterwards, why did the ICD shock her when she was dying anyway? Why couldn't she just slip away peacefully? This is the problem with prophylactic ICDs in very old people. You are preventing a rhythm that might be the most merciful way for that person to die. And in the process, you are extending suffering. A study published in the Journal of the American College of Cardiology followed older patients with ICDs and compared their outcomes to older patients without ICDs who had similar cardiac disease. In patients over 80, there was no difference in mortality between those with ICDs and those without, but those with ICDs had more hospitalizations, more complications from the device itself, and lower quality of life. The device did not help. It caused harm. The Talmud teaches that one should not prolong the dying process. It teaches that dignity in death is a sacred value. And it teaches that the elderly have the right to refuse interventions that will not benefit them, but will only extend suffering. This wisdom applies directly to prophylactic ICD placement in very old people. The third surgery that I want to discuss is more subtle, and it relates not to a single procedure, but to a pattern of aggressive intervention in the elderly. It is the pattern of repeated interventions, repeated stent placements, repeated hospitalizations, repeated procedures in people over 75 who are in the terminal phase of their illness. In modern cardiology, we have tools that are powerful and effective for certain situations. We have catheterization labs where we can place stents in blocked coronary arteries. We have the ability to monitor patients continuously. We have medications for every possible cardiac condition. And because we have these tools, we use them. Often, we use them even when the evidence suggests they will not help. I had a patient named Samuel, 87 years old, from Chicago. Samuel had advanced heart failure. His ejection fraction was severely reduced. He was hospitalized 8 times in 1 year with acute decompensated heart failure. Each hospitalization involved intensive treatment, diuretics, inotropes, catheterization to look for blockages that might be contributing. Each time, we would stabilize him and send him home. 2 weeks later, he would be back in the hospital with the same problem. This pattern continued for months. Finally, I sat down with Samuel and his family and asked a direct question. Are these repeated hospitalizations extending Samuel's life, or are they extending his dying process? His daughter, who was a physician herself, began to cry. She said, "They are extending the dying process. He does not want this. But every time he is admitted to the hospital, the doctors start the protocols automatically." What Samuel needed was not repeated intensive interventions. What Samuel needed was honest conversation about what was happening. He had advanced heart failure. That was not going to be reversed. What he needed was palliative care, management of symptoms, comfort, and dignity. He needed someone to say to him, "We cannot cure your heart failure, but we can keep you comfortable, and we can help you spend your remaining time with your family rather than in a hospital." Samuel chose to go into hospice care. He lived for 4 more months. Those months were spent at home, with his family, without the trauma of repeated hospitalizations. By every measure of quality of life, those 4 months were infinitely better than the 4 months that preceded them, which were spent in a hospital. This pattern, aggressive intervention in the terminal phase of illness, is not unique to cardiology. It happens in oncology. It happens in pulmonology. It happens throughout modern medicine. And it is driven by several factors: fear of litigation, fear of abandoning the patient, the financial incentive to perform procedures, and the cultural belief that doing something is always better than doing nothing. But the Talmud teaches something different. It teaches that there is a time for intervention and a time for acceptance. It teaches that knowing when to stop is as important as knowing when to begin. And it teaches that dignity and comfort in the final stage of life is not a failure of medicine. It is the goal of medicine. Now, I want to be clear about something. I am not suggesting that all surgery is bad for older people. I am not suggesting that older people should never have medical interventions. What I am suggesting is that there should be a fundamental shift in how we approach the elderly with serious illness. Instead of asking, what procedure can we do, we should ask, what will extend and improve the life of this particular person? For some 80-year-olds, an intervention is absolutely appropriate. If you are 80 years old but you are vigorous, your mind is sharp, you have many good years ahead of you, and an intervention will extend your life and your function, then that intervention makes sense. But for someone who is frail, who has multiple comorbidities, who is in the terminal phase of illness, who is declining despite maximal intervention, further intervention often makes things worse. This requires honesty. It requires a willingness to have difficult conversations. It requires doctors who are willing to say, I cannot help you with surgery, but I can help you with comfort and with dignity. And it requires older people who are willing to hear this truth and to make their own decisions based on clear information. I had a mentor early in my career, a surgeon named Dr. Martin Kaufmann. He was 78 years old when he had a stroke that left him partially paralyzed and cognitively impaired. His cardiologist wanted to place an ICD because an echocardiogram showed some reduction in ejection fraction. Dr. Kaufmann refused. His family asked me why he would refuse such a simple procedure that might save his life. I told them what doctor. Kaufmann told me, Cohen, I have spent 50 years operating on hearts. I know what these devices do and what they do not do. I know that I am in the last phase of my life. I do not want my death prolonged by a machine. I want to die as myself, with my mind and my dignity intact, for as long as possible. A device that extends my dying process is not a benefit to me. Dr. Kaufmann died 2 years later, peacefully, at home, with his family around him. He died at 80. He lived fully until the moment he died. That is different from extending his life for another 2 years in a state of progressive decline, which is what might have happened if he had agreed to aggressive intervention. The shift in thinking that I am proposing is not radical. It is based on solid evidence. It is based on the wisdom of the Talmud, and it is increasingly being acknowledged by thoughtful cardiologists and geriatricians, but it is not yet mainstream in practice. Aggressive intervention in the elderly remains the norm, and people continue to suffer because of it. What would change if we shifted this paradigm? First, we would have fewer surgeries and fewer procedures in people over 70. Second, we would have more honest conversations between doctors and patients about what interventions will and will not do. Third, we would have more palliative care, more hospice care, more focus on comfort and dignity in the final phase of life. Fourth, we would save billions of dollars that are currently spent on interventions that do not help. And fifth, and most importantly, older people would live their final years with better quality of life. This is not about abandoning older people. It is about caring for them wisely. It is about recognizing that the goal of medicine in the final phase of life is not to extend life indefinitely, but to extend good life for as long as possible, and then to support a peaceful death. I have written down the evidence behind this shift in thinking. I have compiled the research studies, the ethical principles from the Talmud and from modern bioethics, and the practical steps for having these conversations with your doctor. The link to this guide is in the description below. Because this knowledge is too important to be confined to academic journals that most people never read. You deserve to know this. Your family deserves to know this. Your doctor needs to hear from you that you understand this. If you are over 70 and you have been recommended for a major surgery, I urge you to ask specific questions. Ask whether this surgery will extend your life or extend your dying process. Ask what the outcomes are for people your age with your condition. Ask whether there are non-surgical alternatives. Ask your doctor directly, if I do not have this surgery, what happens? And listen carefully to the answer. And if you are a family member of someone over 70 who has been recommended for surgery, I urge you to have the difficult conversation. Ask questions. Seek a second opinion. Consider whether aggressive intervention is truly in your loved one's best interest, or whether comfort and dignity might be a better goal. My grandfather Mordecai taught me something that I have carried my entire life. He said, "The greatest act of healing is sometimes to stop trying to cure and instead to comfort." I did not understand what he meant when I was young and eager to operate. I understand it now. After 40 years of surgery, after all the lives I have touched and all the lives I have lost, I understand that sometimes the most profound healing is to acknowledge that some things cannot be fixed, and that the goal is to live as well as possible with what is. This is not defeatism. This is wisdom. This is the Talmudic principle applied to modern medicine. This is the accumulated experience of millions of human lives throughout history, teaching us how to age, how to die, and how to maintain dignity in both.